So welcome everyone. My name is Elizabeth Keating. I'm the clinical program director for California Bridge, and I have had the honor and the privilege of working with Dr. Reb Close for just almost 5 years as well now, Reb. It's been a while that we've been working together. So it's really been an honor to support Dr. Close side by side as she really shows best practices and what I think is a statewide example in how to treat young patients who are struggling with drug use. So, Reb, you can go ahead and introduce yourself and we will go ahead and dive in. Thank you all for being here.
Yeah, thank you so much for being here, and thank you so much for having me. And this is tough knowing what to do for our pediatric patients. And so it really takes these conversations, and I say a conversation for a very deliberate reason. I'd love to hear as we're going through this, probably we'll hold questions to the end, but your experiences, direct questions, things that have come up for you, we all learn from each other in this work because this is a new this is a new world that we're dealing with. So just to introduce myself, my name is Reb Close. I trained initially in emergency medicine and worked in my community ER for 20 years. Started developing a pretty significant interest in addiction medicine about a decade or so ago, and then did my practice pathway addiction medicine boards last year. And I've been working full time now in 3 different clinical settings. And I think these are important. So when you hear me reference my patients, you'll know who I'm talking about. One of those clinical settings is a private practice clinic that's associated with one of our pain clinics. We got some grant funding so we can take care of anybody, which is amazing. And then another clinical setting I work in is in our street-based clinic. And that is literally, put a tent, buy a van. We have harm reduction supplies, and then we get patients into MOUD if they are interested. And then the last clinical practice I'm in right now is in our jail, helping again to connect those patients to treatment and ongoing care. So when I'm talking about what I do and what I see, those are the circumstances that I'm explaining from. So super grateful to be here. Because of my ER background, I felt pretty comfortable addressing adolescents with what aren't considered pediatric problems, and addiction is clearly one of those. And so that's how I kind of got into this niche of really helping to develop guidelines and working with experts and figuring out how we can get our adolescent patients really the top-notch standard of care that they deserve. So we realize it's kind of a complicated group, and so that's why we're going to talk about this treatment today. So let's dive right into it. So of course, CA Bridge, I appreciate so much everything that we're able to put together as a group. And I personally have no financial disclosures. I go back and forth with brand and generic names, so I do apologize for that. And I want to get a shout out to Alicia Gonzalez because she's been working with me on a lot of this stuff, and we do this all as a team, so it's really awesome. Okay, first, you're here. And I think that's really important. This is a somewhat challenging and frightening population in every ways. As an owner now of an adolescent, it's a little scary. And so thank you for acknowledging that and for being here. This is a group that I find responds really well to open arms and kindness. And so please understand that I appreciate that you're bringing that as well. This is a challenge. I will, anything for adolescents can be a challenge. And so I appreciate you for rising to that challenge. One pill can kill was part of my medical training, right? The certain things that in a toddler, one pill can kill. This now applies to anybody. And, this is a really unique circumstance that we're in, and we need to rise to this occasion. And these patients have the rest of their lives ahead of them. So if we can get them into recovery, who knows where they're going to go. And so just realizing this population is so incredibly special, and we need to approach them with that respect and awe in many ways. So we're going to run through some clear objectives here. So we're going to go through the landscape and trends, just so you guys know, kind of level setting what is going on out there. We need to talk about the MAT or MOUD basics for our youth, okay? Legal and ethical considerations. That's always a big question. So we've got to make sure that we're really clear on that. And then some of our youth-specific outreach and engagement strategies. Again, this is a special population, and we need to approach them in a little bit of a different way. And then there are harm reduction strategies for adolescents, and so we need to discuss those as well. So those are our objectives for this presentation. So let's get right into it. Okay, so getting some background here. 1 in 7 of our high school kids have used drugs. And that's really a vague thing to say, but that's kind of the data that we have from the Youth Risk Behavior Survey. So that's a lot. You realize, the typical high school class or how many students are on a campus, that's a lot of kids that have been using substances. And 1 in 5 of our 12th grade students have been reported to use prescription drugs without a prescription. And this is a big way of how this all started. As we know, the home medicine cabinets, getting prescription pills from a friend, all those kinds of things. That's a lot of how this started. And it's seen and perceived by our youth as less dangerous. It's very rarely reported that a first-time use is, I'm going to use heroin, or at least it was. It was, oh, I got this Percocet from my mom, or oh, I got this Xanax from my grandma's medicine cabinet. And so those prescription drugs without a prescription is really a lot of how this starts and has started. So I think that's really important to know is of our high school seniors, 20% have used drugs in that way. And what's crazy is that our adolescents have the fastest growing rates of opioid overdose and hospitalization. And there was a 182% increase in fentanyl overdoses in our teens over the last 3 years. And there are a number of different statistics that are available. This is from the CDC's unintentional drug overdose reporting system. But those trends show that, from the last half of 2019 to the last half of 2021, there was a 109% increase in average monthly overdose deaths among the adolescents. And so it's just really the scope of the problem. We cannot look the other way. We cannot assume that it's not as bad as it is. We need to talk about this, and we need to understand that these kids are really high risk of overdose, hospitalization, and death. And this was the information I was just referencing as well. Drug overdose is the leading cause of death for our Californians aged 15 to 44, and the rates of fatal overdose are fastest rising among our population 15 to 49. Overdose deaths among teenagers, this group 14 to 19, has increased 370%. So again, a younger population, I'm asked all the time, what are the age groups we're seeing our overdoses and our fatalities? Definitely younger population, and this significant increase in our teens. Okay. Here's the other problem. We all know that very few patients with addiction and substance-related issues and risk of overdose, that they get treatment at all. And unfortunately, our adolescents have the lowest rates of access to treatment. In part, that is exactly what we're talking about today, ethical and legal considerations, parental consent considerations, all of those things. It's also people not being comfortable with this population. It's a little interesting. When fentanyl first came to my community, we realized we had 2 populations now. We had our patients that were experiencing long-term dependency and addiction. They had really high tolerance. That was one group that was impacted by fentanyl. And the other was my experimenters, my kids, as I call them very affectionately in my community. And when we had 2 distinctly different groups with distinctly different risks, we have to kind of pivot to respond to that. Many people are more comfortable treating that first group than obviously the second. And so just a whole mindset had to change because of the risks in the community and the risks of the drugs on the street. And what's crazy is when you ask my patients when they started using, my patients that have been using for years and years, the most common age that I hear is 12. That's just by far the most common. Kind of more in the general information that we have, it's around first use of age 15 or at age 15, but most people don't get into treatment until their mid-20s. And so if you think about it, if you start using at 15 and you don't connect to treatment until mid-20s, that's potentially a decade or more of time with continued use and maybe legal consequences and all these things where they're not getting into care. I mean, you want to talk about a formative decade? Think about what happened in your own life from 15 to 25. Like, we're missing a very, very important and formative time in their lives where access to treatment is an additional challenge. So just realizing we have this opportunity to change that, and starting by communicating and working together. All right. So I started seeing this trend in my hospital, and we were seeing a lot of presentations with intent of self-harm as the reason for an ingestion. And I say that pretty specifically. This is from the American Association of Poison Control Centers, and these are their ingestion with intent of self-harm calls to the Poison Control Center. And as you can see, trending this from 2000 to 2021, you can see a steep increase in the totals across both. So teenagers by definition are 13 to 19 on the left, and oh, the one on the right, it looks like the label got changed, but that is for the pediatric cases. That's, I believe, ages 6 to 12, that graphic. And you can see they both have gone up really dramatically, changing it around 2010. And specifically, you can note on here that is in our female patients. And so that is presenting to the ER, or I'm sorry, presenting with a call to Poison Control Center with an ingestion with the intent of self-harm. You see those numbers going up dramatically. So attempted suicide or other ingestion associated with self-harm. So the concern is there are a lot of mental health challenges that are facing our youth right now. We all know that, but what does that translate into as far as poisonings and overdoses? And I think that's something we also need to continue keeping an eye on. And we do trend this in my community because it's obviously, I think, really important to discuss. So with all of that, I think it's pretty clear to say that substance use is a pediatric disease, and we need to be able to have teams and knowledge and comfort in taking care of this patient population and offering them evidence-based treatment. All right, so let's move forward into what's going on with the adolescent brain that makes them so susceptible and so high risk. And so, you know, we all have our normal kind of dopamine levels. 40 is the worst day ever, 100 is the best day ever, kind of that range. Well, our adolescents actually start with lower levels. And so they feel the lows more and they feel the highs more. And so this release and surge has a greater impact for them. And we can all think of this, you know, back in adolescence, the first kiss, our best days ever, you know, the horrible fights with our families, you know, these emotions are felt so dramatically, in part because of the different levels of dopamine that are present in pediatrics. So you add that, the emotions are much greater. They're also, the research shows that our prefrontal cortex, you know, that this is a good idea or this is not a good idea, part of our brain, that doesn't really finish developing until our mid-20s. And so as you can imagine, that 15, 16-year-old developmentally aged prefrontal cortex just doesn't really weigh that as it would if they were 25, 30. And then, of course, risk-taking exploration is part of being a teenager. Like this is what we in some ways need to do to really understand boundaries and what is safe and what am I interested in and who can I trust. That's part of growing. And so when you add all of this, it's like the perfect storm. Then you add in illicit drugs, and it's, I mean, as far as increasing the impulsivity or decreasing the inhibition, it's a setup, you know, in many ways for them to be really high risk, not able to appreciate the consequences, get those big changes in their dopamine levels. It's a setup for them to be at high risk. And as you can see from the earlier information we're talking about, leading to these poisonings, overdoses, and deaths. Okay, now we talk a lot in addiction medicine about patterns of use. So there's abstinence, experimentation, recreational use, right? In adolescence, I argue, and I argue this pretty firmly, that any use right now in our current drug environment can be as concerning as a substance use disorder. So, you know, you get to, I don't use the word abuse anymore. This is definitely kind of part of the prior vernacular, but continued use despite negative consequences, dependence and addiction. Even before that, experimentation, recreation, social puts them at tremendously high risk. And so, you know, I apologize to my students when I'm teaching. We go to a lot of the schools and talk to the kids. This is a really dangerous time to be a teenager. And that experimentation or recreational social use unfortunately, in this environment could lead to horrible addiction, if not death. So I acknowledge that this is hard on the kids and that it's just a different environment for them. So, okay, so I kind of painted some bleakness there. I don't mean to, but this is kind of the reality, and we got to talk about it. So the question is, what can we do, right? So I just mentioned that I go to the schools, and so you educate the students, you educate the parents, you educate the teachers, anybody who will listen in any way. We try to educate them, try to inform them about what's in the drug supply. We post that all the time in the information that we're sharing is what's in the drug supply. What do they have to watch out for? Destigmatizing. We've made such strides in using destigmatizing language, and we need to continue with that and be very respectful of how important it is to do that. Obviously, we need to reach out into the community, reach out to the schools, reach out to where kids are congregating. Obviously, prevention is our goal, but we also need to start treatment, and that's what this is all about today. So we're going to run through this, and I think the little graphic is slow, but that's okay. There you go. Okay, moving on. Okay, so let's run MAT in youth. And the kind of beautiful thing is you already know this. So, our California bridge model is low barrier treatment, connection to community, and culture of harm reduction. So let's run through this, low barrier treatment. Everybody knows this. It's something we just need to keep an eye on and keep in our hearts when we're taking care of these patients. OUD, as we all know, as you initially start using substances, you get that euphoric effect. Then the next time it's not quite as much. And unfortunately, with how the body responds physiologically to these substances, over time you use just to feel normal. What MOUD does is bring you back to feeling normal without the substance. Basically just get you back into that normal range. And obviously then as I describe it to my patients, you just get on with your life, do what you normally do. Okay. Critical part here, and this is something I hold so true when I'm taking care of my patients, is buprenorphine saves lives. So when you look at people who have OUD and are not in treatment, they have a greater than 6-fold risk of death. I mean, it's just what it is. When people are on MOUD, when they're in treatment, that rate comes down to closer to the general population. We've got to get patients into treatment to keep them alive. And as I was talking with my adolescent patient yesterday, we want buprenorphine in her system. So if she uses pot, that in my community does have, there's some of the pot out that's not from the dispensaries, that it does have fentanyl in it, that she's protected if she chooses to use pot that day. So literally, we just need to get people into treatment that are at risk for overdose and death. And number needed to treat, we talk about it all the time in medicine. As you can see, to save a life, you have to give 42 people aspirin that are having a myocardial infarction. 42 people have to be treated in order to save a life. Buprenorphine for opiate use disorder, it's less than 2. So if you treat 2 people, you'll keep one in treatment, and then you suffer the mortality risk. You will be able to prevent that death. All right. This is where it gets actually really easy because we already know this. MAT works. I mean, just treating opiate use disorder works, whether you're 15, which is one of my patients, or 60 and change, which is another one of my patients. Okay, so the medications, we already know these. Obviously methadone is our full agonist. Naltrexone is our antagonist, and bup is what we're going to talk about now. And this is why I absolutely love it so much. I was talking about this with my patient yesterday, is the ceiling effect. So because it's a partial agonist, it binds that opiate receptor, blocks it from being bound by fentanyl, and it partly activates it, but it doesn't fully activate it. So it treats the respiratory, treats the cravings, prevents withdrawal, prevents overdose, but doesn't cause respiratory depression and sedation and potential fatality that happens with the full agonist. And it's a sealant. So you can take more and more and more bup, and you're still at that same level. And so that's really helpful to kind of keep in mind as you're treating patients. It's just so ridiculously safe. And I'm really grateful for that at this point, given that everything else is so crazy. So obviously normalization is key. Just like any other disease that we treat, I always talk about asthma. I always talk about diabetes when I'm talking to my patients and their families. You treat the emergencies and crises promptly. Expect that there's going to be bad days, specifically in adolescents. I mean, think about an adolescent with diabetes. There are good days, and there are really not good days. So that's part of this. Some people are going to do really well with treatment. Some are going to have a more challenging time. Open arms is always my answer. When they're ready, we're here. So how do you start a kid on bupe? Exactly as you start an adult. Did it yesterday. It's exactly the same. There's nothing different. There's no weight-based dosing. Bupe is approved for those over 16 plus. I very comfortably will use it in the under 16 crowd. And we'll talk with how we do that regarding the parents and consent. But this is widely supported. Like, we're good. Okay. There's no change from the medications. What you would do for your 25-year-old is the same you do for your 16-year-old. Just the only caveat is with some of the consent, which we're going to hit. Okay. So this algorithm, and it's changing soon. So I'm not going to spend a lot of time in it. We've updated it with more information that we have on fentanyl. But it's the same thing. You treat the withdrawal, you give them buprenorphine. If there's precipitated withdrawal, you give them more buprenorphine. You guys know this. So just keep in mind, there's nothing on here that says, 18 plus. This is the same algorithm. So just kind of breezing through these again, because everybody's familiar with it. You can do home starts, you can do ER starts. I do both very comfortably. I call them street starts for my patients that are literally unhoused in a tent, no access to regular toilet needs, and no running water. We start it. Like, it's a heck of a lot safer than what is otherwise happening in their circumstances. Okay. You wait the period of time after that first dose. If they're not getting better, obviously we consider maybe undertreated withdrawal, talk to them about side effects, check in on what's going on, consider other medical comorbidities. But really, if they're doing better, you give the second dose. You really need that load in them. And that's how I do it for my patients. Just kind of get them loaded up, make sure they're feeling well, and then you can continue with our treatment plan. Discharge prescriptions really depend on what availability of services you have for your community. So if you can get people in really quick, you can have a safer case for making a shorter prescription, 1 or 2 weeks. Especially for an adolescent population, I would ask, write it longer, because they will have more challenges getting connected to care. As I mentioned earlier, they're least likely to get into treatment because of a lack of providers, which we're now going to change, I hope. But please be aware that they will need a longer prescription, and our sons, our other teammates can really reach out and make sure they're maneuvering through the system. So I would ask if you are comfortable, 4-week prescription. I have no issue with that, because it's a heck of a lot safer than the other stuff that's going on. All right. So now here's the meat of this, is the ethical and legal stuff, right? So this California Family Code is pretty clear for California. So if you're in another state or another area, please look up the information for your area. But for us, minors 12 to 17 may consent for any drug or alcohol related problem for their intake and evaluation, application for services, workup, treatment plan, medical care, except MAT, I'll come back, individual and group counseling, hospital care, anything related to drug and alcohol problems from age 12 to through 17, they can consent. That's it. Like, there's the code. You've got it, quote it, you're ready to go. Here's the challenge. Parental consent right now, and I'm hoping this changes soon, is required for participation in MAT, MOUD, like ongoing treatment. That's required. Okay. Now, if they're emancipated, then obviously that's different. If I'm in that situation, I'm going to have to talk to hospital legal or figure that out if they're emancipated. Living apart from the parents, managing their own finances, all that stuff. But that's for MAT. That's for ongoing treatment, not for treatment of acute symptoms. Very different. A patient in front of me who is in horrid withdrawal, they're shivering, they're pylorect, nausea, vomiting, diarrhea, they're in horrible withdrawal. That's treatment of pain and suffering. I personally, and many of my colleagues as well, will use buprenorphine in that situation because it's so darn safe, just like we were talking about. That's not MAT. That is not ongoing treatment. That is acute treatment of pain and suffering in an acute circumstance. That we feel is absolutely something the patient can consent to. If you can't find the parent, whatever's going on, you have to treat pain and suffering. We have to. Like, you wouldn't, if a child had a femur fracture, you wouldn't withhold fentanyl if you felt that was indicated for that fracture while you were getting their parents. Same thing. So please just keep in mind that rule in that code 6929 is for ongoing MAT. This is different, acute pain and suffering. So when in doubt, treat pain and suffering. They can consent to all of that treatment. They can consent to all of those things. Work figuring out with your legal team or with the parents or however you're going to do ongoing treatment. But the acute pain and suffering, we have to treat. Okay, ethically, we just have to. Okay, this is the other reason it's so challenging. For our CMC certified OTPs, or opiate treatment programs, they have federal laws they have to follow. Someone under 18 must have 2 documented unsuccessful attempts at short-term detox. They have all these rules they have to follow, which decreases the number of providers able to treat this population. This goes back to the why of why are so few adolescents getting care. This is part of that, right? So if the ED is starting them on care, and of course, MAT for a prescription for outpatient initiation of care to have the parental consent, they might still have trouble with follow-up. So you've got to really make sure that you're working with your team to get that follow-up done, because they may have the additional barrier of, with the OTPs on the outpatient setting. So your clinics, you can work this out as well of how to make sure that patient's getting the care they need while they're kind of maneuvering through the system. Okay, let's keep running on this. We're getting there. So this goes back to what I was mentioning. Is parental consent required for treatment of withdrawal in the ED or hospital? No, not for supportive care. So yeah, I could choose to give clonidine, antiemetics, something else for pain, or bupe. It's not bupe alone. It's bupe for MAT that needs parental consent. So I can give you bupe in the ER when you are 15 and you're in horrid withdrawal to treat your acute pain and suffering. If I want to write you that prescription, I need to work with your family on it, or need to confirm that you're emancipated. Okay. So just to clarify now, the consent of sharing of information with the parents, okay? So I just mentioned that if you're over 12 to 17, you can seek treatment for drugs and alcohol, no consent needed. You're good. So with that, I must obtain their written authorization to disclose this to their parents, unless their parents are who brought them in for treatment. Then I have to tell the parents what's going on. So if the parent brings the child in for drug treatment, then we have to communicate with the parent, and the child needs to know that, okay? If the child presents independently, I need their consent to tell their parents. So I hope that's clear. Fortunately, the vast majority of my patients, their parents already know, they're directly involved in the care, so the consent is very clear. But just so you realize that in that situation, the parent brings the kid in, you have to talk to the parent. If the child comes in alone, you have to get their consent to talk. Okay. Sorry, I know there's a lot of legal stuff here, so we try to make it as the way my brain works as possible. We try to keep it clear. Pro tip, and I just mentioned this, the vast majority of my parents, number one, they already know, truly, it seems. My parents, they're scared to death. They're going to lose their kid. So they're usually very involved, and we just try to bring everybody together. That has absolutely been my overwhelming experience as we're working as a team. And I reference that to my patients, their parents, and my team, is that we are all in this together. So group conversation is the request. Okay. Just like the femur fracture, medical emergencies do not require parental consent. That provider has to reasonably believe that the medical procedure should be undertaken immediately and that there is insufficient time to obtain the consent. The femur fracture, the pneumothorax, whatever it may be, you make that judgment call, and then bring in your risk team, whatever you need to do when you're talking with the parents, whatever has to happen. Medical emergencies do not require parental consent, so please treat the patient in front of you, treat their pain and suffering, and make sure they're safe. Okay. Now, what if the parents are divorced, or what if only one is present, right? This is, again, hospital risk teams or clinic risk teams are really important to bring into this if you need to. Always best, like I said, pro tip, group conversations. If they both agree, have them both sign, and then you've just got it covered. If they disagree, then it's the risk stuff for the court order, the custody order, who's doing healthcare decisions. So it's a little more challenging, but you are that patient advocate. So please realize that that patient, specifically in one of these situations, needs you even more to really advocate for them and to make sure that their voice is heard and they're getting what they need. Okay, so that's the legal stuff. The MAT is pretty straightforward, I think. And this again, kind of what I do, and I've really put myself in this niche because this is an incredible population that I want to get into care. So now let's talk about outreach and engagement. Where are the kids? Well, they're in the middle schools and the high schools. I already talked about how I go there too much. But what about your after school programs? Boys and Girls Club? Where do they buy food? Where do they hang out? You know, skate parks. We're putting posters in our skate parks. Social media is giant. You know, we're working actually with a group of youth in our community for their social media networking communication. So they're sharing the information with their peers. They would much rather hear from a peer than from me. Trust me. So use that to help get the word out, help them understand what they're up against. This is a totally different world than we grew up in when we were adolescents. So enlist their peers to help them understand, because the message will be much better received. Okay, couple of things about how we talk to and with our adolescents, and obviously stigma is gigantic. I actually ask when I'm presenting or teaching that if I use stigmatizing language to be called out, because that's the only way I'm going to do it better. So person first language, patient with diabetes, a patient diagnosed with bipolar disorder, please really keep this in mind. My patients actually use far more stigmatizing language than I do. And I gently remind them that I'm not going to use that language because I have tremendous respect for them and for what they've been going through. Okay, so when you're opening these conversations, like I said, I was just doing this yesterday with a teen, do they know what's going on? Maybe they do, maybe they don't. And so do they really understand the risks? When we were talking about how the cannabis in my community has tested itself positive for fentanyl, do they know that? And so just having those conversations, they may not know, but they may. And then what are their thoughts? My patient yesterday, she's like, I just don't want to overdose and die. Okay, I can work with that. I can totally work with that. And so we came up with a plan based on that. What was her thought for why she was engaging with me? She just wanted to live. Genius, right? Just we tap into that, make sure I know what her goals are, and we work with that. Okay. And then back to that whole consent issue, do the parents know? Do we have permission? Who brought the kid in? You got to make sure that's all on the table. And you got to be really upfront about consent, because nothing will break trust by them realizing you have to tell mom they didn't know that. So just put it out there and make sure that they're aware. Obviously, they're all individuals. And if you think about to our own adolescent days, we all had the ways we like to do things. We all had the ways we didn't. So please respect that. And I talk about a team. I do this all the time. I thank them. Please know how grateful I am that I'm able to partner on this with you. And realizing that I tell them it's an honor and a privilege that you will allow me to help. I think it's important. All right. Obviously, interviewing techniques for adolescents. The fortunate part of living in an ER for 20 years is I get really comfortable with uncomfortable conversations. But, if you think about it, encourage their questions. Talk about stuff that's easy first. How was school today? There's one of my students I always start out with, hey, how was school today? How were your grades? I know you were working on some stuff. What was that project you did last time? Just keep it easy. Sometimes that, the icebreaker type of a thing. Confidentiality, obviously, privacy, and the legal stuff we talked about. This really isn't a time to lecture or be judgmental, as you know. They probably get enough of that. So, you're their ally and their teammate. Obviously, talking about them is never appreciated by any of us. Watching our nonverbal cues as well. A lot of active listening, re-engaging with things that they say, and just trying to be really clear and really honest. I say all the time, I don't know what's going to happen next. I don't know what's in the pill that the next person's going to have you or give to you. I have no idea. And being honest with that, I think, is really important, and making sure that you kind of clarify what they need to know and want to know to make sure you're speaking the same language and you're all on the same page. All right. So then we get to what else we do with the bridge, right? Connection to care. And I talked about some of the challenges, which obviously that's why we work as a team with our substance use navigators and our outpatient treatment programs to get people connected. And then also harm reduction. I am not going to think that the patient I took care of yesterday is not going to use any substance ever, no way. I don't. So I really need to come up with a way to keep that person as safe as possible. Okay, we have a lot of different things for harm reduction. Narcan is amazing and genius, and we would be lost without it in this current environment. Talking really quickly about Narcan distribution for kids, the California Narcan Distribution Project literally has schools and universities on their list. So that's where we're putting it, is on the schools. Any drug or alcohol related problem, if you're over 12, you can consent without parent or guardian. And the laws aren't really explicit. They don't lay it out black and white here, but any minor who's using even cannabis in my community is at risk for an overdose and therefore should have Narcan. I feel very safe and comfortable in prescribing Narcan or just handing it to my youth. And remember, we're required to offer Narcan for any opiate prescription, which buprenorphine is. So I think we're totally covered with Narcan here, and I hand it out liberally to my adolescents. Absolutely. There was a podcast just published on this with Never Use Alone, and I make sure this is on all the information we give to our adolescents, because using alone is just, it can't be done. It's just too dangerous. This is a hotline that you call, you tell them general demographics, what you're about to use. They stay on the line with you. If you stop responding, they send EMS. It's a way to get around that, the shame, the fear that whatever it is that keeps someone from using with someone, it keeps them alive, which, I mean, if they die, they never get a chance to get into recovery. I have really candid conversations with my students about fentanyl test strips. It's only as good as it is when you use it and how you use it. I tell them all the time, if someone hands you a pill and says, no, I totally tested it, it's fine, it's actually a lie, because you cannot have a pill if you tested a pill, because you have to dissolve it into solution in order to test it. So I tell them point blank, if someone hands you something and it's in a solid form and says, I tested it, that can't happen. So just educating them on what it is. And then just remember, it's like a pregnancy test. It's positive, negative. Doesn't say how much, doesn't say where, just yes or no. So there are some concerns with that, but it's, again, educate them with the information that you have. Okay. So wrapping up, and then we'll take some questions. We talked about the drug use among our adolescents and the fact that they need better access to treatment. Buprenorphine is safe. Use it in minors. Dosing is exactly the same. Don't even think about it. Same situation, 100%. Minors over the age of 12 can consent for assessment and treatment, Narcan, everything that they need, except for outpatient ongoing MAT without consent. That's where that consent comes in, and I need you to bring that up with their families and try to enlist everybody in the same conversation. Motivational interviewing is great for every age group, but I think it's really important here to make sure that you're on the same page and that their questions are answered and their concerns are addressed. And then obviously harm reduction saves lives. We need to reduce stigma. And I treat patients with diabetes that are 15. Why wouldn't I treat someone with OUD? So normalize our treatment. Here are our bridge resources. They are amazing. We have a youth specific tool that we put together a while ago. I don't think any updates are needed now, but if you find something that you're finding needs to be updated, please let us know. And then thank you. That's me. Ta-da.
Thank you, Reb. That was wonderful. Got a couple of compliments coming in just to me about what a wonderful presenter you are. So thank you as always for your compassion about this topic. So we have a couple questions from the chat that I'm going to ask you. And one of the first ones that we got, I would love to hear your response to. I love the frank nature of this question. It is, I read data a decade or so ago that adolescents who experiment with drugs and alcohol become healthier, more stable adults than those who don't experiment at all. Is that still true? What has changed?
It's interesting because a decade ago, it was a different environment. I have a really hard time considering the two worlds similar at all right now. Just what these adolescents are up against, I'm really fearful for them. My experimenters are the group I'm the most concerned with right now, and that is that adolescent time period. So when the kid, like I said, I apologize to the students when I chat with them that their environment is so dangerous right now. I would have a hard time suggesting to a student to use currently. Do I have a number of my adolescents that are using cannabis? Absolutely. Are they getting it dispensary only with their family? Make sure, that we are taking every precaution we can. Yeah. So it's just different right now, and it makes me nervous to suggest that we will have the same finding if we were to look today.
Thanks. So I'm glad
Yeah.
that you mentioned teens using cannabis, because there's a couple questions about cannabis and fentanyl in the chat. So to break some of the questions down, one question here is somebody in the chat has heard from medical professionals that fentanyl in marijuana is not a risk because lighting the marijuana to smoke it deactivates the fentanyl. Is that true?
Not in my patients. So I'll just be honest with you. We've had a number of patients that were only smoking pot and went down from fent. So, and we actually tested the pot, like everybody was up in arms about it, arguing about it. And I totally understand there's a lot of controversy on this. So we tested the pot, and the pot showed positive for fent. So the situation was fent, the circumstance was fent, and the pot was fent. So that is not my experience at all.
And what about cannabis that's consumed as an edible? Is fentanyl a risk there?
I think it would depend on where the edible is acquired. I would be concerned. What I tell my patients in general is, if you didn't get it from a dispensary, you do not know where it came from directly from the manufacturer, so to speak, I would not use it. That's just what I tell my patients, in an abundance of caution, just given what I do.
So please use the chat if you have questions about everything that Reb is saying, because a number of questions about cannabis and fentanyl were in the chat. So Reb, while we wait for other questions from the group, I have a question for you. There are a lot of navigators on this chat, and I'm curious, put yourself in the shoes of a navigator who has gone to this webinar and follows our resources and knows that buprenorphine is the appropriate treatment for a young patient who presents using substances. How do they get their providers to write that prescription? The providers are so scared, right? Those teenagers, to quote one of the clinicians who did our youth opioid response project with us, she said, teens using drugs are the fire-breathing dragon of the emergency department. What can you say to those providers?
Yeah. So what we did is gave them the end. So as an ER doc, right, we freak out about, I'm going to do something and then what's going to happen, and I don't even know, right? I am that person. I did that forever. So for my navigators, it's, yes, Dr. Close will see this patient in the clinic tomorrow, right? And so they know that I got this. I have got your back. You give them the medication. And I've actually had a couple of my colleagues only comfortable giving the med like in the ER, right, to treat the acute symptoms. And my navigator has that catcher, as we call it, the pitcher and the catcher. They have that catcher, which is me, ready to go. The other thing is we go back to our providers and provide feedback. So we're saying that, and I have our meeting, I think it's next week, 2 weeks, where I'm going to go back and say, hey, Bob, that patient that you took care of, that 16-year-old, I took care of them in clinic. They're doing great. Thanks for taking care of the patient. So we do that direct feedback to the providers when possible, just to let them know this isn't this big, scary, nebulous hole that the patient's going into, that we're actually reaching back and getting them connected to care. So those are two things I would do, is make sure you've got that recipient and the doc knows that, realize that maybe initially they won't be comfortable writing for a couple of weeks of a script, and then letting them know that, yeah, it worked out, you got this, right?
Great. Well, I hope that helps some of the navigators. So a couple more things. Do you have any experience? Do you know, is 988 equipped to address young patients and drug use? Do they have the resources that are necessary?
I think it's regional.
Yeah, if other navigators have experience with that, you can feel free to share that in the chat as well.
Yeah, I think it's regional. I'm actually meeting with our one of our 988 teammates later today, because again, we're trying to do this bi-directionally. I know what the patients need, he knows what exists. How do we make sure they match up? So
yeah, so make those local community connections to your 988 representatives is a good move. Here's a good question. Is there any data that naltrexone is any more effective in adolescents than it is in adults? Now, they asked about naltrexone. I'm not sure if they mean naloxone.
Oh, for either, I don't know if there's data on it. I'd have to look into it and see if anybody knows. Please add it to the chat or pipe up. Yeah, I haven't familiarized myself with that.
But you know,
Yeah.
our understanding is that both naltrexone and naloxone are safe and effective treatments for adolescents as well as adults, even though we can't speak to the relative effectiveness compared to those
Yeah,
two.
I don't know that.
Yeah. Other
Mm-mm.
questions? And Reb, just a clarification question, what setting you work in? You used to be in the ER and now you're in a clinic?
Oh yeah, so now I work, as I mentioned, in the clinic, in the street clinic, and then in the jail.
Great.
Yep.
Uh, yeah, wonderful. So here's a good question. Some compliments for you, Reb, that follow up and closing the loop is essential when you're in the ED and also working in the community and street medicine like you are. So what can folks working in public health at the, you know, county or municipal level do to support ED doctors and staff? Man, Paula, I don't know you, but I will Venmo you $20 after this webinar for asking that question. What can folks working in public health do to support this?
Yeah. So, in my opinion, remove the barriers. Please, 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 please. So, literally, we have an assessment that's required for our Medi-Cal. It's called the ASAM. I think everybody knows ASAM. I should have said that differently. Anyway, that is required to get someone into one of our Medi-Cal treatment programs. And oh my gosh, it's insane how challenging that is. You know, we'll have patients in the ER, they're ready for treatment today. And it's like, okay, well, let's schedule your ASAM for Thursday. Oh, we only have Thursday at 2. You're in school. Like, you got to be kidding me. If they're ready for treatment, it's got to be right freaking now and deal with all the stuff on the backside, as I see it. You know, it's like we have it's not even a crack in a window for some of these patients of the time that they're ready for care. Every barrier needs to go away. You can deal with it later. And we do that. I mentioned I had grant funding for our one of our clinics, whatever. I don't care if your insurance is from, Tallahassee. Doesn't make a difference to me. Let's get you in treatment and we'll deal with all the rest on the backside. I mean, I got to be honest, this is too dangerous to deal with red tape. So, yes, please, any red tape that can go away forever, that would be amazing. Mine.
Yeah, and in my seat as the program director of Bridge, something I would encourage folks working in public health to do is know what is happening to the opioid settlement funds in your region. So the opioid settlement funds have been sent down from the state to various counties who have done many different things with those funds, depending on the county. Your county might still be negotiating what they're going to do with those funds. Any advocacy you can do so that those funds are used for treatment of patients and not for other efforts such as increased law enforcement is gold seal of approval from us. So if you want to talk more about what we know about your region and how you could frame an ask to your county about what's happening to those funds, we're always happy to hear about that.
That's huge. Getting those funds to actually impact the people that are suffering, that's where it should be. I
Yeah.
mean, that's where this whole thing, that's where we're going to win, is if we actually get some of that funding to the people that need the resources.
So
Totally agree.
a couple more questions in the chat. Just heard somebody chime in. I don't know if that was you, Aiden. Go for about 5 more minutes with questions. I want to encourage navigators who are facing challenging youth situations to reach out to our navigator team. Latoya, who you should know. If you don't know Latoya, reach out to us. We will introduce you to Latoya. She is actually the person who I learned about this particular topic, treating youth patients, from before I even met Reb. So she's a wonderful resource for some of the patient-specific questions that are coming in. Call Latoya. She'll help you navigate your challenging patient stories or patient situations. So here's a question that you might have some feedback on, Reb. What happens long term to teenagers who are getting MAT? Is that medical history that causes them to be denied insurance, or does insurance cost more? How long do teenagers stay on MAT? Do they have to stay on it forever?
That's a really interesting question. And kind of like COVID, we don't know all the long-term consequences that are going to happen because it's so new. I mean, I feel the same for MAT for our kids. This is really new. And we don't have decades and decades and decades of information. The insurance question is a very valid one, something I would definitely, I don't know if we can get I don't know if there's enough history in here to know yet. I do know that a lot of my patients want off, but that's across the board for age. They want off MAT, and we talk about it. It's what's going to be best for you now, what's going to be best for you when you're in a hard situation. I think I think we'll know more as time goes on of what the consequences are long term, what the goals are, but I don't think we've been doing this long enough to have that as solid data. I really try to get my patients that are interested in, yeah, I'm ready to get on MAT because I want to get off of it. I really try to get them to focus on what are we going to do right now? How are we going to keep you today safe? How are we going to keep you alive in the next several weeks to months? And then we'll deal with what we're going to do in 3 years and 3 years. You know what I mean? It's so fluid, the environment right now. And I mean, we talk a lot about fentanyl, but we have xylazine in my community. We have bromezolam in my community. It's like, what's next? I don't know. Keeping you safe. So
thanks,
yeah.
Reb. I also want to respond to one of the questions that I didn't read and just say your questions are not annoying. We love your questions. If we didn't want to answer your questions, we would all go do something else all day. So please ask us your questions. So I think that's pretty much wraps us up today. So please reach out to us. The best way to get in touch with the right person at California Bridge is to email info@bridgetotreatment.org. That will get very quickly to the right person. That is a email that is monitored by a real live person every day. So we'll get to me and I can get to Reb or any other resources that you need. One final closing note here that we've said a few times, but Reb, I just really crystal clear. Why is the environment so dangerous for experimentation today?
Yeah, I saw that. And oh my gosh, yeah, fentanyl is what kills people the fastest, right? We have carfentanil in my community, acrylacetyl, you pick it, right? Fentanyl is what's going to kill them. But I mentioned xylazine, I mentioned bromezolam. Like my fake Xanax used to be fentanyl, and at least I knew how to treat it. And I had an overdose reversal agent in Narcan for it. Bromezolam, now I have a bunch of people that are addicted to this crazy benzo that just makes them horribly psychotic. And we have to deal with benzos now. So no, I mean, fentanyl is the most imminent threat to the life at this moment, but there's all the other stuff. And it's going to change. I mean, if I'm giving this lecture, in January, it's different stuff. That's why I was actually really excited to be reminded that we're doing the trends.
Yep.
What's next? That's when people ask what I'm most concerned about. It's the what's next. That's exactly the what next. Oh, the other drug I mentioned was bromezolam. Bromazolam. Bromezolam. Yeah, it's a synthetic benzo that never has been approved for human consumption, and it's showing up in our drug supply locally. Because why not?
So just to wrap up, I want to answer the question about whether there is CME for this great session. Well, thank you for the compliment, Carlos. I agree that Reb gave us a great session today. So the good news is that this presentation is available for CME through our learning management system, which we set up to offer CME that will allow providers to meet that 8-hour DEA training requirement on addiction and pain medicine that's now required for license renewal. You also can watch it to get CME for whatever you need CME for. So we can include the link to that session. We do these live so that we can answer your questions in real time, but you can also go to that Relias link and share it with any provider you know who might be interested in learning about buprenorphine administration for youth or for any other special populations or just in general. The nice thing about the learning management system is it is a choose your own adventure format. So you can go in, create an account, watch Reb's lecture, which is identical to this one today, just without the interactive Q&A, get the CME for it and move on. And you can also do, as many other hours as you need to do, but you can do it as a one-off if you want to. And since you've already watched this, you could probably watch it pretty quickly and answer the questions. So yeah, thank you, Reb, for what you do in the community every day. Please reach out to us if we can be of service, and we look forward to hearing more of your questions. They're not annoying. We love them. So I hope everyone has a great rest of your day, and we'll see you soon. See you some of you next week, maybe in person in LA.
Thank you. Thanks so much. All right.